Good morning, everyone. And over the next few minutes, I'm going to talk a little bit about the adjuvant and neoadjuvant therapies and what's new in breast cancer. And it's truly been a last 2021, which has been really very exciting for us. Can I have the control, please? Okay, so yeah. So a year ago, these were the therapy standards for early breast cancer. And as you can see in the luminal type, we looked at the risk of recurrence. And if it was a low risk, endocrine therapy alone, and a high risk were given chemotherapy. In addition, we gave extended hormonal therapy. And in premenopausal women, ovarian suppression was performed. In the triple negative space, a lot of these patients went in for neoadjuvant. And if there was residual disease, adjuvant capecitabine was used. In the HER2 space, again, in the low-risk disease who had surgery first, the abbreviated de-escalated APT regimen was used. And in those who had neoadjuvant with residual disease, escalation was done with TDM1. Clinical trials for both for early breast cancer follow a risk-adapted approach and incorporate both escalation and de-escalation strategies. So let's review the data for 2021 and see if we're going to change our practice based on this. So let's start with the ER positive subtype. And the most important trial presented last year was the Monarch E. As you remember, this was for a high-risk lymph node positive group and patients with a high risk based on clinical features, which were node positive, or high risk based on Ki67 were randomized 1:1 to abemaciclib for 2 years with endocrine therapy versus endocrine therapy alone. And the reason that FDA probably did not approve this right in the beginning was because the follow-up wasn't sufficient, and we know that late recurrences are very common with endocrine therapy. So with a 27-month follow-up and a 3-year disease-free, invasive disease-free survival, delta 5.4% advantage with the addition of abemaciclib, this treatment is now approved and the hazard ratio is 0.69. How about the safety? So we're all concerned with safety, especially in the adjuvant setting over 2 years. So patients experience diarrhea, fatigue, cytopenias, but what is important to remember, you can also get other serious AEs and SAEs like venous thromboembolism and interstitial lung disease, which seems to be more with the abemaciclib. There were also dose reductions in a large number of patients and dose interruptions as well. On October 12, 2021, the FDA approved abemaciclib in the adjuvant setting for HER2 negative node positive patients, ER positive with a high risk of recurrence and Ki67 of more than 20%, along with a companion diagnostic. And you can look at the table below, which basically showed you that this is the really high risk group which exhibits primary endocrine resistance. And there is a delta of 7.1% versus giving no abemaciclib. So you can see in the continuous lines on the graph on the left side, these are the groups with a high risk with high Ki67, and the prognosis remains very poor for this group. So this is the group where we are supposed to use abemaciclib. But the biggest question remains, why are the results different from other adjuvant trials? And we saw results of Penelope B over the last 2 years in Palace as well. And there were a lot of explanations thrown around that the population was really high risk for Monarch E, that the percentage of discontinuation was high in the other trials. But the final results of Palace presented at SABCS last year showed that amongst the intention to treat population, the IDFS was just identical at 4 years. So will the results of Monarch E change practice? Yes. The only issue is the reliability of Ki67, and we have to get used to doing that routinely. We have to use the DACO assay as is prescribed in the companion diagnostic. What do we do with the younger premenopausal less than 35 with 1 to 3 nodes positive? These are the patients that do really badly, and could we use abema in them? And how are we going to manage the diarrhea and other toxicities in the adjuvant setting? What about duration of adjuvant AI therapy? So there were 2 studies presented last year. The GYM4 was presented. This was postmenopausal, early patients who had received 2 to 3 years of tamoxifen, patients had mainly T1 tumors, 40% node positive, 54% prior chemotherapy, and early discontinuation rate with 5 years versus 2 to 3 years of letrozole was much higher. Now you can see that the 11-year results, both the DFS and the OS, were significantly better in the arm that had received 5 years of letrozole following 2 to 3 years of tamoxifen. In contrast to this study, we had the ABCSG or the SALSA study, which again included postmenopausal, but they were a very, very low risk population. And here, whether you gave 2 to 3 years or you gave 5 years, the results were identical. The DFS was the same, but the risk of fractures were double in the 5-year group. So there were differences. Will these results change our practice? Not really. Most postmenopausal patients don't reach tamoxifen. They receive AIs upfront. And for this group, we usually stop AIs after 7 to 8 years, maintaining bone health and giving them the advantage of extended treatment. This is also borne out by the results of the ABCSG study. And if one starts with tamoxifen, then continuing AIs for 5 years rather than 2 to 3 years, as based on the GIN4, becomes reasonable. What about genomic testing? There were a host of abstracts and data last year. So let's look at RxPonder, which might change our practice. So here, patients with RS 0 to 25 to informed chemo benefit in the low node population was studied. And postmenopausal patients did not benefit from adjuvant chemo. The IDFS was identical at 5 years. However, the premenopausal women did benefit with almost a 4.9% difference with the addition of chemotherapy. This was further corroborated by MINDACT updated analysis, and there they looked at age for chemotherapy addition in less than 50 years, and the distant metastasis-free survival at 8 years was significantly better in the patients that got chemotherapy. And the take-home message from this is that ER-positive patients who are premenopausal still seem to derive benefit from adjuvant chemotherapy in addition to hormones. Triple-negative breast cancer we handle next, and there's been a question of platinum in the neoadjuvant setting with 2 trials, one showing a benefit in DFS and EF and OS, the other not, while both showed an improvement in PAT-CR. So this question, I think, has been settled once and for all by the results of the brightness presented recently with a follow-up of 4.5 years, where you can see that the addition of carboplatinum to paclitaxel gave you a EFS delta of 10.8%, which is really huge, in addition to improving the PAT-CR. However, the addition of the veliparib did not really make a difference. Will the results of brightness change practice? Yes. We've already been using platinum in the neoadjuvant setting in large node positive tumors. Our threshold for using it, at least mine, will now be lower. It is reassuring that along with increased PAT-CR, you get a survival benefit as well, but there is no benefit from adding a PARP inhibitor. What about use of platinum in the adjuvant setting? It is controversial, and these results prove it. So the ECOG-ACRIN study randomized patients with residual disease to capecitabine cycles versus cisplatin 4 cycles, and actually showed that the major criticism of this study was that both arms did fare rather badly. Coming to the main point, which is immunocheckpoint, and we're all very excited about that. There have been a host of randomized studies in the neoadjuvant setting for triple-negative breast cancer, and the updated results of Keynote 522 from ESMO Virtual Plenary actually showed a meaningful EFS benefit of 7.7% compared to chemotherapy alone. And this EFS benefit was seen across all patient subgroups. And what was amazing to see was even in those patients who had pembrolizumab and did not achieve PAT-CR, they did better than their chemo alone counterparts. And this data is further strengthened by mature results from GEPAR-NUVO, which shows a significant 3-year IDFS benefit with the addition of durvalumab. The toxicities with IO in the neoadjuvant and adjuvant setting always have been a concern. And will the results of Keynote change practice? Yes. Pembro can now be incorporated into the neoadjuvant setting with anthrattaxane and platinum. But what is less clear is if the patients achieve PAT-CR, are you going to use it and continue using it in the adjuvant setting? Adjuvant olaparib was also presented in ASCO plenary last year. This was for germline BRCA mutated patients and high risk, those who had no PCR in the triple negative group or T2N1 disease. And in the ER positive group, which were a minority, only 20%, a high CPS EG score or more than or equal to 4 positive lymph nodes. They were randomized to olaparib for a year versus placebo. And if you look at the results, the 3-year invasive disease-free survival was 8.8% better in the olaparib group with a hazard ratio of 0.58. And there was a trend in overall survival. Dose reduction was 25% in 25% in these patients, and there was fatigue, GI, and bone marrow toxicity as expected. What about the subgroup analysis? As you can see here, patients who received prior chemotherapy with platinum also seem to benefit from the addition of olaparib, but I must warn you that these numbers were very small. Olympia change practice? Sorry. Will the results of Olympia change practice? Yes. It will encourage germline BRCA testing at diagnosis. The benefit in the ER positive population is less clear. The results are driven by triple negative, and the toxicity post chemo is a concern. Coming to HER2 positive disease, the major advances in this setting have been in the metastatic setting with TDXD. However, for early breast cancer, we now have a fixed dose combination of PERT and TRAST as a subcutaneous injection that can be given in the clinic in the thigh over 2 to 3 minutes. And this would be a boon for our patients. Will this be practice changing? Yes. My question is, will it be affordable? And that will really dictate its use in India. Coming to the last contentious bit, and we've been fighting about this for a long time, is the duration of trastuzumab. So finally, last year, there was an individual at ESMO of individual IPD meta-analysis of 5 RCTs of the duration question. And as you can see, the result was that 6 months is non-inferior to 12 months, but 9 weeks is not non-inferior. And we have our very own data from Dr. Gulia and her group, which showed that they did both an IPD and a trial level meta-analysis, and they showed that the curves are just superimposing on each other. And they too concluded that 6 months is non-inferior to 1 year. So is this practice changing? Yes, 6 months is preferred to 9 weeks. And for ER positive, node negative, yes, I would encourage it for those who can't afford and refuse 1 year of treatment. So how do the treatment options now look in Jan 2022? So basically for luminal disease, we have the addition of abemaciclib for 2 years for the high-risk population. For the HER2, we haven't made much difference since the last year. But the real difference seems to be in the triple negative breast cancer space. So here we do early germline BRCA testing rather than later. We try to give our patients more neoadjuvant chemo. We add platinum. If affordable, we add pembrolizumab. If there is a PCR, question of continuing IO. If there's no PCR, we continue the immunotherapy. Do we add metronomic in high risk? If the patient is also BRCA mutated, do we choose between immunotherapy and olaparib, or do we give both? If the patient is BRCA negative with residual disease, do we give capecitabine? In those that can't afford olaparib, who are BRCA mutated, can we then offer them capecitabine? In the adjuvant setting, in the high risk, we give olaparib, or if they are BRCA negative, do we use metronomic capecitabine for 1 year? So these are many, many questions that remain to be answered. And nevertheless, this is a very exciting time for breast cancer, especially triple negative breast cancer. Thank you so much.